Hello to everyone. It is a great pleasure for me to be here today with you. A very warm welcome from me. I'm Luciano Saso. I'm a Vice Rector at Sapienza, University of Rome in Italy, and Professor of the Faculty of Pharmacy and Medicine. Today we have an excellent webinar on digital solutions in health of the series on innovation in health professions education. Health professions education is changing rapidly in most countries, and the recent digital push given by the COVID-19 tragedy is accelerating the process. Topics like simulation, machine learning and artificial intelligence, digitalization and big data are becoming more and more important. Students of degree programs related to health should also be exposed more and more to ethics, intercultural training, communication, in order to perform well in the new global and digital society. That is why we are planning other webinars in this series on ethical issues in the near future on September 30th, and machine learning and artificial intelligence on October 28th. I would like to thank very much Professor Stephen Cantor, President and CEO of the Association of Academic Health Centers International, Christine Kaller-Smith, Director of Member Programs, and Habiba Belghedi, Program Manager. Thank you, Habiba. You really always do a great job in organizing these webinars. I would like to thank all distinguished speakers for having accepted our invitation and all participants for being online with us today. Without further ado, I would like to give the screen to the first speaker, Dr. John Mahoney. John is an expert consultant on medical education, innovation, and accreditation, building upon 2 decades of experience as former Associate Dean for Medical Education at the University of Pittsburgh School of Medicine. He led changes in medical education, methodology, and content that have significantly influenced the curriculum of Pittsburgh and beyond. He applied his background in bioengineering toward developing innovations in simulation, curriculum delivery, pandemic preparedness, and telemedicine. So with great pleasure, I leave you the screen for you, John. Thank you.
Well, thank you, and good morning and good day to everyone. And Professor Saso, a quick question. I understand that one of our colleagues has a clinical activity quickly here. Would it be all right if we quickly change the sequence of events? I know this shakes things up a little, but I think Dr. Nadine has a pressing clinical situation.
Okay, with pleasure. So we can start with Nadine. Yeah, with pleasure. So let me then introduce Nadine, another excellent speaker. So thank you, John, for saying that. It's always a pleasure to try to adjust the program also to the needs of the speakers. We change and we start with Dr. Nadine Haka-Karam. She's the recipient of a British Empire Medical Medal in the Queen's Birthday Honours for 2018. She's a surgeon, lecturer, and clinical entrepreneur. Nadine drew on her passion for innovation, education, and global surgery to found Proximi, an augmented reality platform aiming to improve access to expert care and to scale clinical expertise. Proximi has enjoyed significant success with early adoption by major medical institutions and device companies, and has been covered by new agencies around the world. Nadine has been selected as an endeavor entrepreneur, is a member of the Royal College of Surgeons Commission on the Future of Surgery, consisting of some of the country's leading doctors, engineers, data experts, managers, and patient representatives with the objective to investigate the advances that will transform surgery over the next 20 years, and the faculty at Singularity and Exponential Medicine. She's also the clinical lead for innovation at Guy's and St. Thomas Hospital. So it's a great pleasure to leave you the screen, Nadine. Thank you.
Thank you so much, and thank you for the flexibility and the reshuffle. I really appreciate it. I've got some slides to share. I hope everyone can see them. Thank you for inviting me. I'm a big fan of this organization, of course. I know for years, my sister was directly involved as well, kind of connecting this to the Middle East. So it's a real pleasure to be here. And as you mentioned, today we're talking about digital solutions at the intersection of health and education, I think, which is a bit that I've been really interested in for probably the last 10 plus years. But perhaps to give a bit of my background and work. So I trained as a reconstructive plastic surgeon. I'm originally Lebanese. I grew up in California and then moved to Beirut during my teens. And I experienced firsthand a lot of that disparity in healthcare and variability in access and variability in knowledge transfer. As a surgeon for 10 years, I was passionate about global health. I was very excited about, how we bring new products and new innovation to the operating room. But ultimately, all of it was limited. It was limited because of the scale at which we could do it, at the pace at which we could do it, and ultimately a lot of the variability involved in it as well. As a surgeon, I experienced firsthand those challenges that we have around variability. And it's not a challenge just of some parts of the world, it's something I experienced across the whole world. And so I decided to think about how do we address the problem, this variability of access, variability of knowledge and skills, a problem everywhere, not just somewhere. And the reality is we need to start to think differently about surgery and about the operating room. I started to imagine operating rooms all around the world virtually connected to enable immediate real-time skills transfer, knowledge sharing, coaching, mentoring, training, education, product launch at pace. Imagine a world where every patient could get access to the best care the first time, every time. And of course, a lot of the thinking stemmed from knowing what surgery was and I guess how it's kind of evolved or lack thereof. If we look many, many years ago, surgery was, really the genesis of it was collaboration, communication, co-presence. A beautiful part of surgery. It's what I love about surgery as well, the collaborative approach, the communication approach. But unfortunately, what we did is we didn't really evolve this model, which was probably fit for then, to the current world. And so we still find ourselves inviting many people to enter an operating room to learn, to train, to educate, to scale, but recognizing that this brings with it a lot of variation. I'm sure you'd agree when you look at this picture on the right, it's not really conducive to scale, and at most it's going to introduce a lot of variability. And this is something we're seeing, in fact, today. Today around the world, there's variability across operating rooms and surgeries. In the UK, for example, you're 14 times more likely to suffer complications following colorectal surgery between one hospital and another. In Sweden, you're 36 times more likely to suffer complications in cataract procedures between one center and another. And in the US, you're 3 times more likely to die following surgery between the lower performing hospitals and the higher performing hospitals. But the reality is surgery affects all of us, either ourselves, our loved ones, our family. There's a study that showed in the US that in your lifetime, you may have between 7 to 9 procedures, however minor or major they are. So this is actually something we have to look at really closely. We also have to look at this closely because today 5 billion people around the world lack access to safe surgery, which is something we can't accept, 2/3 of the world's population. This idea that quite simply where you live will determine if or how you live should no longer be acceptable, should no longer be the status quo, and we should be making a difference here. And so what we try to do is really think about how do we combine the best of human expertise with the most advanced technologies to enable exchange of knowledge and to help save lives? How do we bring to the operating room a digital environment? The operating room has traditionally been very analog, undigitized, kind of like a black box, not knowing actually what's going on in the OR. But imagine if we could bring and share that expertise at pace and at scale. And that was really the thesis behind Proximie, a software cloud-based approach able for anyone to use anywhere in the world, a global solution for a global user base, designed by surgeons for surgeons, knowing full well the intimate experience of what it's like to be a surgeon, what it's like to be in an operating room, and what it's like to work with a team. And today, Proximie is in over 40 countries, delivering that scale, performing over 10,000 aided events so far, doing close to 1,000 events per month, and anchored in significant evidence with published articles in peer-reviewed journals. And for those who know surgery well, you'll know the mantra, see one, do one, teach one. We have to move away from that. The see one, do one, teach one is analog. It's undigitized, it's siloed. There's no real way to track it or understand what value it brings and how to measure someone's performance around it. What we've been advocating is change that to a fully digitized experience. Prepare, perform, perfect. A continuum. Because surgery is not about a moment in time. No matter where you are in your career, you're going through that revision. I'm going to prepare, I'm going to perform, and I'm going to perfect. Imagine a single platform would enable you to dial into live cases or dial into a library of high quality videos. When you're ready to perform your cases, you can have trainees dial in to learn from you, or mentors that you've worked with before dial in and give you a second pair of eyes and virtually scrub in. And imagine every single case was recorded and tagged and stored in a HIPAA and GDPR compliant way, so you could actually go back and review that, get feedback, and think about new models of care and new models of kind of accreditation around this as well. I kind of often think about this in the matter of sports. I used to play soccer as a university student, and I think what sports has done in terms of becoming more data driven, in terms of the value of coaching, is something we can learn from in surgery as well. So I'd like to share this video with you that helps demonstrate that, I hope.
Technology is changing our pursuit. Just look at the world of sport, the pre-game plan, the post-game review. Every angle, every possibility, watched, reviewed, applied. What about the clinical world? At Proximy, we enable clinicians to virtually scrub in and collaborate with each other from anywhere in the world, allowing any clinician to prepare, perform, and perfect their craft. Pre, during, after. Think of us as your game tape. Start your pursuit today. Plug in Proximy. Connect clinicians. Save lives.
And I think what's really important is to know that we're leaning on, years and years of evidence. There's significant evidence that demonstrates that video analysis and coaching is fundamental in surgery. It accelerates learning, it reduces the learning curve, and ultimately, therefore, harm to patients. And so if the evidence is out there, how are we not now making this the norm? How is it not the norm that every operating room is digitized, that every case is recorded, and that we're using this and leveraging this to scale expertise, give feedback, and optimize quality? And so Proximy, what's beautiful about this platform and this software is that your user is a lifetime user. Whether you're a first-year medical student, a resident, or a surgeon at the top of your game, you're constantly going through this virtual cycle of continuous improvement. How do I prepare? How do I perform? How do I perfect? And we've already demonstrated that we're able to double care provision in half the time without compromising quality and not making it more costly either. And why we've had so much success today, and as I said, we're in several hundred hospitals around the world already, is because from day one, we took a global approach. And we took very purposeful design decisions to ensure that this can really integrate into complex systems, complex environments like the operating room, where you're not going to be able to change everything, but you can become an adjunct in that environment and become a go-to platform in it. And so Proximy today is global. We can deploy Proximy in any country with local data centers and local requirements, not only to enable that scale, but also to enable us to deliver an ultra low latency experience, and for this to work on low bandwidth. So much so that the UK military actually chose Proximy as their partner of choice for field hospitals to support training and coaching, but also because we have such an ability to deploy this in an agile and rapid way. Proximy can be spun up in any hospital within a matter of weeks. And for anyone who's been through a 9 to 12 to 2 year digital transformation process in a hospital, I'm sure this is music to your ears. The other bit is that we've really taken this ecosystem platform approach. There are many interesting technologies that are popping up around the space of a digital operating room, but being the single platform that can aggregate and pull all these technologies together is fundamental. I'd love to share with you a video that just shows Proximy in a bit more detail and how it's used.
And anything that we can do to improve accuracy obviously will improve the outcome of the patient. And that's really what we're focusing on by working to develop these platforms.
With Proximy, I've been using it really heavily since May. I was introduced to the technology during COVID. And it's just been a game changer. I am able to, every time I operate, have another surgeon in the room.
I think this technology works brilliantly. You know, the fact that I can see you perfectly, I can hear you perfectly, and I'm literally in the middle of fracture clinic on an NHS Wi-Fi on my ordinary laptop.
Desai is a neurosurgeon, but he's our endovascular fellow. And he was able to handle this, using this technology. And that's why we think this is extremely important. So for a junior fellow to be able to handle a case like this just speaks to how we can really democratize good endovascular technique, expertise around the world and help patients around the world.
And of course, what we really do is, the beauty about what we're trying to do and what my mission is as a surgeon, still a practicing surgeon, is that, I want to bring in solutions, that intersection of digital education training for impact. It's not to just use technology for the sake of technology, but actually to use it to make a difference, to touch lives, to support surgeons, to scale. And this is a great story of Mo, who was a young adult, sadly at the height of COVID, had developed metastatic testicular cancer. And he'd undergone, chemoradiotherapy and needed to have his surgery now. But the surgery was complicated. All the tumor was wrapped around the vessels in his abdomen. And normally in our hospital, they would have done this through an open procedure. The challenge here was that this was COVID, and there was a lot of concern about, how this patient would stay in hospital for a protracted period of time and the high chance of him catching COVID in hospital. And so what we were able to do is actually link in a world expert on this procedure who does this routinely robotically, to link in with one of our robotic surgeons and for them to work together on this case. 3 to 4 hours later, Mo was back in the recovery ward, and 3 days later, he was home. And 7 days later, he was on TV doing an interview, fully well, feeling energetic, and feeling really privileged to have had the opportunity to have this technology impact him and his life, and hopefully steer away any chance of him catching COVID during that really critical time. And so it's those beautiful stories that make the difference. Our ability to support our, our frontline men and women as they're delivering care in environments where they don't have every specialist in the field, but now they're able to bring Proximie into the field with them and bring experts to dial in and support them through those difficult cases. And of course, there's many more stories of how Proximie has made a difference, as early as when we were first caught by CNN identifying this as the future of surgery. But the bit that makes me most excited, of course, is how we're continuing to deliver impact and make that difference. And I believe as we see the future over the next 2 to 3 years, every surgical operating room, every cath lab will be digitized. Education and logbooks will become digitized and video aggregated. Video performance metrics will form a fundamental core part of what we do in surgical training. And we really have to shift this paradigm, because a siloed approach will never solve a systems problem. And the approach that Proximie is taking is bringing it all together. Our software enables real-time communication connectivity. It enables visualization with overlay of augmented reality and imaging and scans, as you would have seen in the video. But it also enables us to capture data and predictive analytics to start to drive a more intelligent operating room for the future, to hopefully unlock value and revenue across the ecosystem. Because as we know, the operating room is not just about the patient and the surgeon, it's really about all the key stakeholders that sit around the room. And today we're really excited because there's a huge opportunity here. Proximie is global. We're driving towards a connected surgical care, a digital experience in the operating room, but mostly we're a mission-driven team. We really care about patients and surgeons, and we want to make sure that we scale this expertise wherever possible. And finally, I want to leave you with a story, which again, I hope resonates again with the idea of impact. This is a patient, she was several years ago now, she was probably late 50s, and she'd suffered really major complications following a laparotomy that she had done. This left her to have tube feeding. She was in intensive care a couple of times. She almost bled to death once or twice and had a really protracted recovery period over 2 to 3 years. Unfortunately, it left her with a significant abdominal hernia and really giving her very poor quality of life. Every time she would get up or cough or move, everything would bulge in her stomach and would be in and out of hospital quite a lot with pain and obstruction in her abdomen. Eventually, she was reaching a point of desperation, and she reached out to us and said, I really love my local surgeon. I want to stay with him. I trust him, but I would love to have an expert from around the world who does this more regularly to guide and support my surgeon through my reconstruction. And so we obliged, and we brought in a surgeon from London for them to work together. And she was home 5 days later, and the next summer was at the beach in her swimsuit with her grandkids, enjoying her life to the fullest. And this patient is my mother. So I hope what I demonstrated to you is really the kind of the proof point. If you're willing to put your own family through this solution and technology, that means you really believe in it. And I hope that that's at least a takeaway message from here. I want to thank you for your time and your patience and allowing us to reschedule the order. Thank you very much.
Thank you very much, Nadine. A really very inspiring presentation. Congratulations on your amazing work. It's really very, very relevant, especially, about, what you mentioned about really the inequalities that we can see in the world, in many aspects, but in this case related to health. And I think that you really are contributing in a very significant way to the reduction of this inequality. So this is really very important. I know that you have to leave, so maybe I ask also the other colleagues, the other panelists, if they want to come also back to the screen, and maybe if you still have a few minutes, we can do a very short, condensed discussion, and then of course, I know you have a patient to take care of. I also encourage colleagues in online, if you want to put any question in the chat, it would be very nice to receive also questions from you. So I don't know if the other colleagues, the other panelists, if you have any comment or questions for Nadine, please go ahead. Yes, I see John and Elaine. We start with Elaine, so we have to women first.
Thank you. Very interesting presentation, Nadine. Thank you for that. I was wondering if you see an application eventually outside of the OR. I'm a pediatric emergentologist, and I wonder if in other critical care areas you see an applicability of the technology.
It's a great question. Thank you so much for asking. Absolutely. So we started off in the OR, but we saw because what it really is that kind of immersive collaboration, right? And so we've seen it being used in emergency rooms, in intensive care sites where you might be doing procedural things like putting in a central line or putting in any devices, an acidic tab, whatever it may be that you need to do. Even in the community with things like wound care, where you're trying to provide that kind of support at home. And of course, what we've seen a huge growth in is around interventional suites. So interventional radiology, interventional neuro, interventional cardio, particularly as some of these specialties, and we've seen that evolution over the last decade or two, have moved very much into interventional procedures like cardio, neuro, neurology and neurosurgery, stroke. So when we started with a couple of specialties to build a depth and breadth, but we've really seen a huge growth across it. One example, even in the pediatric space, has been around pediatric orthopedics for congenital anomalies. So you're trying to see them out in clinic, looking at how their gait is, their walking, and then how do you move into the procedure room to look at an arthroscopy or whatever the other procedure may be for hip dysplasia or other conditions. So I think the application is very vast in terms of what you can do with it. It's really about the champions that want to take the toolkit and take it and evolve it into the use cases that they have. And I mean, truly as a surgeon myself, and having been in that environment where I'm driving innovation, we really want to engage with decision makers in hospitals, clinicians, nurses, scrub techs. Scrub nurses use this to support each other with new kits, where we can really see the scale around this.
Thank you. And now, John, you wanted to intervene?
Could you give us an example of how to, or does this translate to a strictly training environment? So before the real case, before the big day, how would we use this with that fellow, that resident, to help them get ready for the day when they get to hold the instrument and drive the train?
That's an excellent question. I can give you two examples. So one is, as much as Proximie is being used in ORs and kind of real life clinical environments, we're also being used across the world, really, in CAD labs, in simulation labs and simulation centers, where you're able to almost expand access to those environments. Historically, we all did it. You spend a lot of money to go to a center to do a course, and then you leave, and it's very much, what they call mass learning. You come in for 5 days, it's everything in 5 days, and then you leave. There's no distribution after that. Whereas what we're finding is that in these environments, if you can, as a remote learner, dial in weekly and see these cases being done, that aggregation of knowledge becomes more cemented over time. The second thing is, on the library, every single case is recorded. And what we have is a function called collaborative review. So say I'm about to go into this case next week, and you're an expert on that case, and I'd love to have a discussion with you about a similar case you might have done a month ago. We can actually click on that video and invite each other into a collaborative session. And that video will play, and you and I can use all the illustration tools, the annotation tools to talk through that case. And you can say, look, this is where I made my decision. If you see, I've gone in this plane, et cetera, et cetera. So you can almost take a video and bring it back to life. So rather than having static video libraries, which, they're valuable to a point, here you're taking a video library and you're recreating it into a live case in a safe environment. So you can talk through all the steps, all the pitfalls, things to look out for before you go in. And then when you do go in, you can have that coach and mentor dial in, even if it's for 10 minutes, gives you that extra confidence, gets you going, and you're ready to kind of hit the ground running. And in our OR, in our hospitals, we run a lot of parallel lists, or we run lists where the fellows run it and we're in clinic. You can keep an eye now. I can be sitting in clinic and I can just have a screen and see what's going on. And I may be able to dial in, hey, you're doing fine, keep going, or maybe move a bit more lateral. And it's that kind of engagement is really something surgeons are really enjoying.
Thank you very much. I don't see questions in the chat. Maybe if I don't see other questions, I don't know, Yumana, if you wanted to ask anything. Otherwise, we proceed.
I'm just wondering, how would you see the future of proximity when more robotic surgeries will be? Because then the actual expert can really direct the robotic even from far away.
It's a great question. So I think, I can speak both with my proximity hat and my surgeon. So I sit on the robotics board at our hospital, and I was also one of the key commissioners here in the UK on the future of surgery. So we wrote a white paper identifying what surgery will look like in the next 5, 10, and 15 years. What we see is that we will always be in a situation, at least for the short to medium term, where it's robotic assisted surgery. At the point where we get to autonomous robots, they may be autonomous, but in a particular thing, such as closing an incision or anastomosing some vessels. But there is still an element of decision-making and the kind of surgeon input that will be required, at least for the short to medium term. The other thing I would say is that we are already seeing that with that drive and an explosion really of robotic devices across the world. I mean, every other month there's I think just 2 days ago, Medtronic announced their first Hugo case on the Hugo robot. So we're seeing a lot of these companies come to the fore. And what they're coming to us and talking to us about is, you've got this amazing software solution that can really plug into any device, a video stack, a laparoscopic machine, a fluoroscopy machine, a C-arm, but we can also plug into robots. And so how amazing would it be that if every single robot had a proximity solution or a widget, just like an app on an app store and on a phone, available to surgeons who want to use it for telementoring, for support, for guidance. And just to round it off, I would say we're aggregating petabytes of data on a monthly basis from a very diverse patient population around the world. Undoubtedly, we are going to play a pivotal role in driving that element of data-driven surgery, machine learning, computer vision, AI, as it starts to become relevant. So I think if anything, we're going to be really kind of tied closely to robotics, both as an enabler for autonomous one day, but equally for the enablement of scale of robotic surgery around the world.
Perfect. Thank you very much. Really fascinating, Nadine. Unfortunately, we need to go on. Thank you very
so
much for being with us, for your excellent presentation. And again, congratulations on your work.
No, thank you. I want to thank you for the invitation, and I want to thank my sister Noha Hashash, who's been a big fan of your organization and introduced me to you many years ago. So thank you.
Perfect. Thanks a lot. And also I want to thank Dr. Mahoney for his flexibility to leave the floor to Nadine first. And now I'm not going to introduce you again, so please, you have the floor.
Very good. And now I have to get that. I have to get that energy back again. You got me in the game, and now Nadine has me even more excited about the possibilities here of a platform like that to change how we do things. And I'm going to persuade my computer to play, and I'll do an image check. Am I successfully screen sharing?
Yes,
perfect.
Very good. Always a good first question. So, well, thank you again for the opportunity to join this discussion, and what a timely one it is. And, coming off the pandemic as such a terrific disruptive force, and it's obvious there was a huge negative impact, but we can use this morning as a moment to think about all that we've learned from it. There have been so many disruptive innovations, truly positive innovations. And what Nadine just described for us really didn't come from the pandemic, but what a moment to have it available. Actions are enabled by technologies, and this was definitely a time for action. Imagine if we went into the COVID-19 pandemic before iPhones, internet, FaceTime, everything else. Think of 2019. We weren't doing things all that differently in 2019 than in 1999 or 1979. We still had waiting rooms and classrooms, and I work in accreditation, and we had accreditation teams clustering in conference rooms. And look at what 2020 turned into and how truly different it had become. So what's the opportunity here? We have a moment where we've done really a huge demonstration project around the world on healthcare delivery and in medical education, and at the convergence of those. We can take this opportunity now to accelerate what we've been doing with digital approaches and implementation of the lessons learned during the pandemic. Telehealth has worked, teleinstruction has worked, telementoring has worked in highly developed countries where the technology and the internet support it, admittedly, but we've seen just how much we can do that way. So the next step is to broaden it out. So what are some of the opportunities in particular? Well, I think of it that it falls into a couple of containers. There's the access piece. We can access new content, fresh perspectives, ways of conceptualizing things that are usually only available to those with access to the world's leading teachers and professors. And not every one of our hospitals, medical schools, countries has those people standing by. And so when I hear Nadine talk about bringing the expert really anywhere on the planet, and why limit to the planet? Why not to the space station and beyond? But we can bring those experts anywhere and be effective in doing it. Sharing. Well, aren't we sharing already? Sure, but we've seen here during the pandemic more sharing, and I would advocate this is an opportunity for us to jump forward and share even more, not just content, but methods, patient cases, simulations. We've gotten into the spirit of sharing and helping each other. Let's keep going. And really, beyond sharing, there's genuine collaboration, working together. Around the world, we're reinventing basic lessons, basic education approaches, basic clinical approaches, and we don't have to. We really could develop something in one place and deploy it in 1,000 others through digital platforms that make it easy to have these collaborations. Let's get even more specific. Web-based sharing during the pandemic has been more and even more willingly done than ever. There's been an altruism to share best practices and try and bring everyone along. And we saw it with the rapid deployment of new knowledge around how to treat COVID patients. And think of how naive we were in the first months and how quickly we learned lessons of what worked and what failed. And new techniques as simple as proning went from being an idea in one hospital to a best practice adopted very widely. This was simple, but it was through digital sharing that we understood this was really an effective thing to do. Online delivery. And we're not talking about just Amazon and online shopping. We're talking about online delivery of content and instruction and clinical care. We're doing it more than ever in 2021, and there's no sign that we're going back after the pandemic subsides. The idea of modular materials for medical education is not strictly new, but more and more, these are not just books and articles available through online collections, but these are now multimedia tools that we can share. And with the advancements in the internet, it's more practical to share large materials that before you just couldn't really make the connection and transfer gigabyte files readily around the world. I think the one that is most special for me when I think of global medical education, the possibility of filling in local gaps in expertise on the teaching front and on the patient experience side. Students don't get to see all types of patients in all countries, all locales, all seasons of the year. I think here in the States of how in the summer, students who are trying to train in pediatrics don't see as many patients because the children aren't as ill in the summer. And why should a medical student or a resident have a gap in their learning because of which month they did a certain training experience? We don't have to put up with that if we could use digital solutions to fill in on this. So how would this work? Well, virtual patients could provide us with access to common conditions, yes, conditions that vary by region, or cases with built-in opportunities to adjust the profile of the case for regional differences. And those might be differences in the patient's race or ethnicity or how they'd present. It might be differences in the technology or techniques used to make a diagnosis or treat a conditions. Now, creating simulations of virtual patients is time-consuming and expensive, yes. But once that initial investment is made, one of these cases can be used thousands, really tens of thousands, millions of times. So the return on investment, if the investment is made, is fantastic. It makes it profitable for companies that invest in these things, yes, but it also makes it worthwhile for educators to invest in these because we can get so much distance out of them. This is one of the high return on investment activities in education today. When I think about teaching module libraries, this is so much more than putting books out on a digital shelf and allowing open access. If we build well thought out teaching modules with parameters that allow others at a distance to really know what they're reaching for and provide documentation how to best assemble these into usable curricula, we've really done something. Think about Lego bricks, the children's toy. If you hand any of us a pile of those bricks, we'll make a few little objects. We might even make a tower or a building. But when they give you that instruction manual, you can build a castle from Harry Potter movies and space shuttles and Volkswagen vans and all sorts of things with good instructions. So when we talk about putting out teaching modules, we've got to bring along some sort of documentation or guidance how to make really good use of them. I advocate that not just distance learning, but synchronous distance learning becomes more feasible in this environment. And I think Nadine's example of the professor being able to join the trainee at the operating table is a terrific one. Even in the ordinary classroom, there's a real difference between having a student watch a video of a recorded presentation and having a professor and a group of colleague students sit around and talk about a case. That active engagement is vital. We're not trying to train book smart individuals. We're trying to train doctors and nurses and pharmacists, and they need to be able to interact with people and communicate and think on their feet a little bit. We need the active learning, and so a synchronous component to this through distance learning really can help. I'm not ready to say we're going to go to the University of FaceTime or the University of Zoom, but we're not that far. Here we are today, and we're learning in this manner. And quality improvement, any of these things have moved already to a digital platform. And here during the pandemic, we've proved that they work. So how do we wrap this up? We've seen accelerated advancement of health sciences education and healthcare delivery, healthcare services. We can see this go further. Now it remains to be seen, are we really changing health outcomes? I think we've seen during the pandemic, we've at least preserved health outcomes. We've allowed care to go forward that would have been interrupted. And we've seen students achieve mastery in the health science education front, even during the pandemic. Educators have found ways to keep the curriculum going online, and we can continue to build on this. Clearly, if we waste less effort on reinvention of teaching materials over and over again, there'll be a savings. And these things are pretty easy to distribute at not zero cost, but at an affordable, a modest cost. I'd also suggest that there really is a joy in collaborating with other excited colleagues on these things, even if we don't get together in person. Is medical education a pathway to diplomacy? Can these collaborations break down barriers between countries? Well, I think so. Some of our governments may not agree with each other. Our populations might not even get along. But most of us around the world agree we want good health care for our families, for our children. And so the idea of coming together in health sciences education, specifically physician education, that's my area, we can use that as a way to break down barriers between societies and make the world a little smaller, friendlier place. Now, that all sounds very happy and sunny and rainbows and, well, you know, we need some reality. This is affordable but not free. There are costs to developing virtual cases. Nadine's platform was developed at some amount of cost, and it probably costs something to implement a system like that anywhere, of course. All of this conversation depends on access to the appropriate devices that are keeping up to date and high quality, dependable internet access. And that's not universally available. And even when it looks like it is, the prospect of connecting from the States to someplace on the other side of the planet, it seems like a good idea at the time you plan the project, but it doesn't always go exactly as planned. So, you know, this is a good idea, but still a work in progress. When we develop resources for sharing or set out on a joint venture, we have to remain sensitive to what's available locally and what's the local culture. What's the normal way of approaching a patient with this or that condition? What conditions can we actually talk to a patient about? Which ones are taboo? There are real world considerations in this. And of course, you know, the high technology medicines, devices, diagnostics, they're not universally available. We have to be realistic. The MRI scan or CAT scan that I can order in a blink in Pittsburgh may not be available even at another town 200 miles away here in the States, let alone in a country that doesn't have the health expenditures the way we might have in the States. We still need the humans. We need the physicians to treat the patients, the professors to teach the students. Our professors could feel very threatened by these new technologies. We need to remember to reassure them they're not going anywhere anytime soon. We still need the humans. Of course, the online experience isn't the same as being there. I think of the joy of tasting the new cuisine, of bathing in the sound of a new language in a new city when I go to meet my colleagues in person and try and collaborate over medical education. And of course, I don't get that online. So it's wonderful to see you all today, but I'd much rather come and taste the food in your place and smell the air and drink it all in. And we don't get that digitally. We're going to lose something there. So I'll wrap up by suggesting 3 steps to begin. We would benefit from consortia that help us collaborate and share it on these things. We will need early champions to take the risks and demonstrate feasibility. And again, I'll tip my hat to Nadine and her work as an early champion who really went out there and demonstrated what can be done. And this is real. This isn't just a pilot. This is a real initiative. We certainly would benefit from the support of international organizations as conveners and catalysts, opening doors so that these solutions can be brought to bear readily and breaking down the barriers of geography and government and regulation so that the sharing can be easy and not caught up in a lot of red tape. I want to thank all of you for joining us today and extend thanks before I forget for the invitation to speak today.
So thank you very much, John. Very, very interesting. So we will come back to your presentation later for discussion. Now we continue with the following speaker. It is a great pleasure now to introduce Dr. Yumana Antun. She's Associate Professor of Family Medicine at the American University of Beirut in Lebanon. She's a certified professional in healthcare information and management systems. She's the IT leader in the program for research and innovation in the medical education at the Medical School of the American University of Beirut, where she advises the administration and trains the faculty on the use of IT and multimedia to support the curriculum in both learning and assessment. So with great pleasure, Yumana, the screen is yours.
Thank you, and hi everyone. Let me start by sharing my screen. All right, so again, hi everyone, and I'm going to share with you the perspective of a country where we have limited resources, whether financial or even human resources. I'm from Lebanon, so it's a country in the Middle East. And really the COVID has helped us a lot, although there were lots of challenges. So my presentation will be kind of mostly how the COVID has driven our healthcare education at our center. And I will put it into like 3 themes. So the adaptation, because we definitely had to adapt in the past 1 year. Definitely we had some challenges along the road, and this helped us to have more opportunities for the future. So if we want to go for the adaptation and how we were able to survive the COVID, first, definitely we had to move the the in-person classes to online lectures. We had to do lots of training for the faculty, and some of them just posted some recorded lectures, others went into a live stream sessions. Then we had to think about the assessment, how we're going to assess our students. We used to have lots of face-to-face assessments with mini CX, etc. So we kind of did some twists. So we shifted the assessment to kind of discussion forums, virtual in-class presentations, some group assignments, some Moodle exams to have some knowledge check. Then along the assessment comes the AAHCI. So how we're going to conduct AAHCIs in the midst of the COVID pandemic. Again, some of the AAHCIs were canceled, but others, like in my department, family medicine, what we did is, again, we did some adaptation. So the AAHCI stations moved to like online conversation, a video monitoring. For example, one station was a telephone call. So it was only the student in the room calling the standardized patient and counseling a person exposed to COVID, a colleague on the phone. We moved also to suturing a laceration using a model. So it was kind of adaptation to the AAHCI. Also, we had to run parallel groups and make them less in quantity. The most challenge or the most thing that we needed to adapt to is the grading system, and especially for high-stake exams. So for example, for Med 3 and Med 4, the grading system was changed to pass, no pass, because we felt it's not fair to judge them on grades when not everybody had the same opportunity. However, we elected for the high-stake exams to remain face-to-face, of course, with the making sure like every COVID precautions were done. And we had to, the whole actually campus had to move to Respondus software. And this I will come to it later as was part of the opportunities in our campus as it pushed us to have Respondus software, which is like proctoring from distant. Next, I'm going to move to challenges and I'm going to talk about the clinical rotations. So as John said, the clinical experience is really different than online. Eventually, we are doctors and we need to see patients. And unless we really take history taking from a patient, do a physical exam on a patient, I wonder whether the learning could occur. So what we did is we were very lucky to be able to continue the clinical clerkships for Med 3 and Med 4. I know like many hospitals, they were not able to accommodate that. But what we did is again with a twist. So we did a minimum number of students per clerkship. We did it on a rotational basis. So at least every day we did not have so many students in order to avoid crowding in the clinical areas. Another thing is the practical clinical skills. How would you teach someone a clinical skill if you don't see him doing it? We were again creative, like I teach the clinical skills for Med 2. What we did is we asked them to videotape themselves doing the physical exam on their relatives. And then I would watch the video and then I will give them a detailed feedback about their examination. Maybe your hand was a little bit lower here, maybe the knee should be more flexed, etc. But again, it's a different experience and I don't think it's still similar to the face-to-face experience. However, what's coming good from this COVID and this move to digital health education is like at our campus, we had a wide-based university initiative, teaching and learning with technology. I've been on an e-learning task force maybe for the past 5-6 years at my university, and we were not able to push it forward. Well, in this past year, this committee has really worked hard. The technology office has created a website, lots of teaching workshops, helped everybody to move into an online or a digital platform for teaching and providing their information. So I don't think without COVID, we would have gone that far. Even at our medical school, the COVID pandemic has pushed us to do a medical e-learning task force. This was co-chaired by me and chaired by our Dean for Medical Education, Dr. Bedr, this is where we did some assessment on what do we need to go for the future in order to continue with the e-learning. There's no doubt, like many students did appreciate certain aspects of the digital education, and I think there is a potential to continue with that. And so this e-learning task force has put some recommendations for softwares to acquire, something like what John mentioned, like the virtual patients. We have now lots of libraries. We did explore some virtual platforms similar to what Nadine expressed, but then this is definitely too expensive for such a country with limited resources. And this will come later on about the funding. And finally, I think the COVID really was helpful in even continuing professional education. Through COVID, we had lots of WhatsApp groups. I've been connecting to many physicians. We were exchanging information on WhatsApp, on any update on COVID. I have this patient, what do I do? Even our CME office had a boom in online courses and webinars. Everybody was eager to learn at their convenience, sitting at home. They don't have to travel. They don't have to leave their houses, sitting at rest at home. I'm going to conclude with this slide. I think, yes, COVID has helped us a lot in moving things forward, but we still need to do a lot. I think the first thing, maybe like what John said about committees or somebody to put a framework for the future, I think we really need to redesign our curriculum. We really need to think whether a certain education doesn't have to be face-to-face, no more classroom lectures, didactic information. Maybe we have to redesign the curriculum also to include new skills like telemedicine, medicine visits, etc. Funds is really a major thing because most of these things that if we need to move forward into a digital education, it needs lots of funding. And because these systems don't work together, I think we need to work on interoperability between these systems. I'll give you an example from our experience with the task force. Like we've found, we've searched for certain databases for virtual patients or online didactic lectures from experts. You have plenty on the market. You decide on one, but then you have to customize the students to log into a certain software. And then you go to the assessment softwares, then you have another software which may or may not interface with your learning management system. So there's lots of systems that the student will be exposed to between communication skills, lectures, virtual patients, assessment, and their learning material on their learning management system. So I think there should be a work on making systems work together and interface with our learning management systems. And thank you.
Thank you. Thank you very much, Yumana. Very interesting talk. And so as we did before, now we proceed with a final speaker and then we come back for a general discussion. I already saw a couple of comments in the chat. So please encourage all participants to write your comments or questions in the chat, because now after this final talk, we will open the discussion with all of you. Now it is a great pleasure to introduce Dr. Elena Khalil. She's a pediatric emergency medicine specialist practicing at the Montreal Children's Hospital of the McGill University Health Center. She's also associate professor of pediatrics at the same university. She has an extremely significant experience both in education and in research concerning education. She has been a program director of a residency program, director of education She developed in situ interprofessional simulation program and facilities at the same institution. In terms of research interest, she has been medical co-director of emergency measures and director of pediatric disaster preparedness at the same institution, advisor to the director of public health on the latter subject, and she has many other research interests related to simulation and education, pediatric disaster preparedness, virtual simulation, etc. So it's a great pleasure to leave you the screen, Hélène.
Thank you very much, and thank you for the opportunity to address this international audience. So I'll just start by sharing my screen. Okay, can you see that well?
Yes, please.
Thank you. All right, so I would like to start just by situating my center, the McGill University Health Center that we affectionately call the MUHC. We are a 1,000-bed hospital located in and around the core of Montreal in Quebec, Canada. We employ 12,000 people roughly, of which 1,400 are physicians and 70 or so dentists, many pharmacists. This is sort of the breakdown of how our sites are situated. So the Montreal General Hospital up here, can you see my cursor? I just want to see if you see what I'm pointing at.
Yes, it's quite small, but we can see it.
Okay.
Yes, yes.
So here, the Montreal General Hospital is a relatively old building, as is the Montreal Neurological Institute and the Lachine Hospital. The Montreal General Hospital is a level 1 trauma center right in the core of Montreal, one of two for serving the area. The Montreal Neurological Institute and Hospital is a well-known facility for neurologic pathologies, 75 beds there. Lachine Hospital is a community hospital with a very small emergency room, but that responded really quite intensely to COVID because they serve a vulnerable population. They have 186 beds. And this is our latest state-of-the-art facility at the Glen site. And if you see the yellow box here is where I work. That's the pediatric hospital. Next to it is the adult hospital, and then the cancer center. And behind is the research institute and the education center where I work as well. And we have 145 beds, including 47 bassinets. So that gives you a little bit of an idea of our center. In terms of education, we receive 37, last financial year, we received 3,780 learners at the MUHC. They are roughly distributed 1,500 or so in medical education, so medical students, residents, and fellows. About 1,800 were nursing students, and the balance, somewhere around 400, are in the allied health, dentistry, occupational health, physiotherapy, nutrition psychology, and so on. So a very large gamut of learners that we receive. And we also have a very active international observership program. And so this, I'm taking the opportunity to plug that because I really believe that the observerships are a lead to collaboration internationally. And I think that's very important. So if anyone is interested in organizing for their learners an observership, I would be the person to contact. So at the MUHC, we embrace a multimodal approach to education, training, and continued professional development. I think as probably everyone, we've already heard 3 people mention, but I think probably everyone who is in attendance has seen an acceleration of evolution of pedagogical and assessment methods for adult learners with the pandemic. We are focusing on remote teaching, online asynchronous methods, with the very important integration of interprofessional education, which we're really trying to integrate into the clinical environment, and a greater role for existing and innovative simulation methods in the clinical sites, as well as virtual simulation. So when the previous speaker, when John was speaking about disruptive innovation, I have to say that, yes, the pandemic was tragic on so many levels, but it afforded an opportunity to accelerate the development of our programs. And what I would like to share with you today is how it affected simulation at the MUHC. So simulation, I don't think I need to convince this audience, but it's rooted in adult learning theory, capitalizing on experiential learning. It's well recognized as a valuable teaching method, both in teaching new healthcare workers, so students, residents, but also in training practicing healthcare workers who are working in high-tech environments that are very rapidly changing. So there's new technology all of the time at our tertiary quaternary care center, and they need to maintain their competence. I don't think anyone can really argue with the effect of, simulation, the usefulness of simulation. Simulation promotes interprofessional practice through interprofessional education. It promotes a culture of patient safety through team training, improving communication, coordination of care, and crisis resource management. And so staff culture of safety equals patient safety improvement. However, the increasing needs of simulation in all areas of healthcare and its relative unavailability, the unavailability of space and time in, for example, our university sim centers has really pushed us to develop in situ simulation. So I'll just take a moment to make sure that we're all speaking about the same things when we're talking about off-site, so in lab simulation, on-site simulation, and in situ simulation. Rather than displacing people, so the clinical teams, to an off-site lab, which over the years has proven to be quite difficult and costly. We would often end up in the sim lab, the university sim lab with 5 doctors, and we'd say, okay, today you're going to play the respiratory therapist, today you're going to be the nurse, and today you're going to be the leading physician. And so we would role play like that, which has a value, but it has its limitations as well. And so bringing the simulation on site and in situ, in the actual clinical environment, so which is what you see here, a mobile unit, bringing the technology to the clinical unit where the clinical teams who are very busy don't have to displace themselves and can actually run simulations right in their environment. And this has a huge beneficial effect. So with that kind of definition in mind, I'd like to share with you what has happened with I would say our experience in developing this in situ simulation and how it's been affected and accelerated through simulation. I'm getting a notice on my screen. Am I still sharing my screen okay?
Yes,
Yep.
Okay.
We can see.
Okay, perfect. So somewhere in the spring and summer of 2019, we developed a vision for simulation at the MUHC that seeked to improve efficiency through shared services, to develop simulation partnerships to maximize use of expertise in-house. So we have tremendous simulation expertise, but it's very fragmented. We also are striving to break down silos that replicate cost structures within healthcare education and training. And ultimately, the goal is to improve patient safety and outcomes through quality training. So this is just a quick timeline of how our project evolved and then what happened when COVID hit. So as I said, we developed a vision in the spring and summer of 2019. I submitted a project to the upper strategic and tactical directors level, where I sit actually, and it was approved. In November of 2019, I hired a full-time simulation specialist advisor, which was really the catalyst. For me, that was the important thing because she is the motor behind the development of the project charter and so on, which we submitted in January 2020. It was approved at the strategic level with funding and approval to seek philanthropic support, which, by the way, we're working in different healthcare systems. In Quebec, we have a certain financial climate for healthcare. It's a public system, and we have to, for many projects, we do rely heavily on philanthropic support. So our foundations are very important to us, and we work very closely with them, our hospital foundations. And then in February of 2020, we finalized the business case that we developed with our finance team and submitted it again to the strategic and the tactical directors level. And it was about to be approved. And then, of course, the pandemic hit. So what happened, which was a very interesting thing that happened in our hospital, our directors, our upper management, basically stopped all projects that were not COVID related. And this was an important point because it showed us, we talk about opportunities, but it showed us how in a system that's as vast and large as ours, when there are multiple projects going on, sometimes it's difficult to bring certain projects to fruition, to to termination and fruition. But when everybody focuses their attention on one thing, and I'm sure this is the experience of many of you out there, that when all of these intelligent and motivated people focus their attention on one goal, we can really achieve a lot. And so that's what happened. So we stopped our development, but in fact, we didn't. We had to respond very rapidly to the needs of this pandemic. So if you picture the situation where we're facing a new disease, obviously with many unknowns, personnel were required to respond based on rapidly evolving science. They had concerns not only for their patients, but now there was a new concern for themselves and possibly for their patients' safety. The knowledge and science were evolving so rapidly that sometimes we had daily new recommendations. This was extremely destabilizing to the staff. I can attest to that because I'm a frontline worker. My clinical home is the pediatric emergency department. How do you counter that? So we did a lot of things, and that's what I would like to share with you a little bit in the next couple of slides. So we rapidly opened the COVID Learning Center. So this was an online on our intranet, the MUHC intranet. This was a place, it was like a clearinghouse of all the latest scientific guidelines that were available internationally. And somebody alluded to sharing, this was really very obvious during the beginning stages of the pandemic. So we posted and we would renew periodically as things became known and changed. We would renew the protocols there. And this was really targeting the clinician, for example, let's say the pediatric hematologist who would, or let's not say hematologist, say orthopedist, who was going to be redeployed to an adult COVID ward and who hadn't treated an adult probably in 15 years. What was the essential information they needed to know? Because Friday they were redeployed and Monday they were to start working. All that kind of information was housed there. We also created the COVID Information Hub with our librarians who organized the literature as it was coming out, as only librarians can do, and they did a fantastic job of it. And they assured a daily monitoring of the science in order to support our clinicians and also our researchers and our learners, of course. And then our communications department created this COVID protocol intranet page, and there was a COVID corner. And this rapidly became the go-to kind of over coffee in the morning. You go to the COVID corner and you see what's going on in the hospital, what you need to know, what has changed since yesterday, and those kinds of things. And that was also the place to look for all the latest COVID protocols. So meaning, you know, for example, the resuscitation protocol changed because the science changed. Well, that's where you would find the latest protocol. And my sim team created a temporary sim lab because, as I showed you in our timeline, we hadn't had the time to yet create and we didn't have the space. So we rented one of the, in our hospital, we have some commercial space. We rented one of those spaces temporarily and we created a temporary sim lab to support the in situ simulation that we were going to be doing. So in terms of scenarios, we were mandated to quickly help teach and train the clinical teams about the deteriorating COVID patient, how to recognize, how to respond. So we created a scenario for that. And when I'm talking about scenarios, I'm talking about live scenarios that we brought into the in situ, so into the clinical environment. We also created one for the cardiopulmonary arrest. So in Canada, in Quebec, it's Code Blue. This may have a different name in your centers. So the COVID Code Blue. And then various unit-specific COVID protocols that we ran with the clinical teams. And of course, we had a always standing PPE station, personal protective equipment, donning, doffing. So we trained many staff. As you see, I listed them. I won't say them out loud, but virtually every sector of our hospital went through some portion of our training. And here I'm just sharing a few pictures of what we, some of the simulations we did. So this first picture here at the upper left is the operating room at the Montreal General Hospital, where we were simulating trauma patients and, you know, how, you know, various deteriorations that could occur and how you had to consider COVID in that in those scenarios. And you see this is early in the pandemic because the people are not socially distanced. And in Quebec, we have a 2-meter social distancing. And so later on, we we started to adopt the 2-meter distancing. And here you see on the right-hand side at our community hospital, people are a little bit more distant and we're doing it outside. So here what was interesting, and you see a picture here on the bottom right, is Lachine Hospital, as I said, had a very small emergency room. And for some reason, probably because they serve a vulnerable population, in the beginning of the pandemic, they were having several codes a day, several cardiorespiratory arrests arriving in the ER per day. And they didn't have the negative pressure rooms or the facilities to receive and treat those patients safely for the staff. And so our technical services of the MUHC created these tents that you see behind this. They erected these tents, and within those tents were the resuscitation rooms. Now, this is completely destabilizing, obviously, for the staff. They're not used to running, first of all, we're not used to running codes with our PPE masks. We can't communicate. And then there's the inside-outside team. And then you have the added noise from the negative pressure fan. So it was really quite destabilizing. And we ran many simulations in those tents for the staff, and it was much appreciated. And it served really, you could see it live from one simulation to the next, the increase in competence, the increase in confidence and performance of the teams. So that was very interesting to see. At the Glen site, we had, I'm just showing you a few pictures. I think probably as you, this is the, sorry, on the bottom right, this is the PPE station that was open almost perpetually for anybody to come in and practice donning and doffing. But I think probably in most places, we saw a complete cessation of certain clinical activity. Some sectors were just shut down to be able to respond to COVID. And so for those sectors, the learners were very much penalized. So in the first two pictures here on the left, you see this is a laparoscopic skills practice station and one for suturing. So we set up kind of these models where residents could come in who were not solicited in their clinical work and practice. Here's another deteriorating patient that we did at the Glen site. And at the top here is my colleague practicing a virtual scenario. So that's it. I see you appearing. It means my time is almost up, so I will hurry it up. One interesting benefit of having simulation in a hospital is, as opposed to an offsite center, is that we quickly saw that by having a good relationship with our biomedical team and our clinical unit coordinators, we could recuperate a lot of the decommissioned materials. And so we started to do that, retired materials. So for example, an IV bag that's no longer suited to be used on a human can certainly be used in simulation for many months. And so we started to collect these consumable goods and leverage the industry for donations of equipment and demo products. And so we initiated this MUHC Simulation Green initiative, which is an ongoing sustainable goal of the Simulation Center to recycle, reuse, and repurpose. It has its obvious environmental benefits, and it allowed us to cut costs on consumables in particular and equipment in order to direct funding to where it's needed in education, research, and innovation. And this is just some example. This is the commercial space that we rented, but some of the stuff that we organized that we collected from our decommissioned goods. So to conclude, as we emerge from this pandemic, the hospital simulation landscape is taking shape, where we ensure a program of essential, on the one hand, on an ongoing basis, essential training to maintain staff competence, excellence in team communication, coordination, crisis resource management, and this through interprofessional education. And one example is in preparation for the rare high impact events like disasters and things like that. And always keeping, of course, in mind our learners in all healthcare professions. At the same time, we remain nimble and maintain the capacity to respond rapidly when the need arises, as we did during the pandemic, as I just shared with you, with development of new protocols and teaching of new protocols, new and emerging technologies like ECMO in COVID, for example, and the rare high-risk procedures. I can share, if we have time during the panel, if there's interest, I can share with you our experience with how simulation helped prepare us for an exit procedure, an obstetrical surgical procedure. So that was very interesting. And of course, to support research and innovation whenever it arises. And so with that, I will conclude, and it was my pleasure to speak with you, and I look forward to your questions. Thank you.
Thank you very much, Len. Another excellent presentation today. Really, we had different presentation on different topics with different angles, but all of them really great, and they gave us an overview of really the recent excellent development of the field. In the chat, there were in the meantime some interesting comments. There was one from William Macaria. The affiliation is not mentioned, but he's just sending his sharing his satisfaction, saying that there are excellent presentations, and then he also says how right John is in saying that he can listen and see from Nairobi these presentations without traveling, and would have been actually difficult for him to travel to the US, to Washington, D.C., where this association is based. Then there was an interesting also conversation between Humana and Andy with some links there. Maybe Humana, if you want to add anything there, please do so.
Yes. So Andy asked the question is about the quality of whether the online learning would jeopardize the quality of graduates, and what about student satisfaction? I'm going to answer first the student satisfaction from our experience. As far as the medical students, especially Med 1, Med 2, they really loved it to be online. They study on their own, they look at YouTubes, they stay in their pajamas, they don't have to come in the early morning, sit listening to me. Even our residents, they did not mind moving the virtual, the face-to-face classrooms into Moodle. As concerning the quality of the graduates, I've put a link about our experience with the family medicine residency. So we compared their interaction with the Moodle classes. So as per knowledge, I don't think the quality of the graduates would change if we're just looking at the competency of knowledge that's measured by an MCQ or an exam. And this is also, we saw it from our medical students who sit for the MBMEs, and actually they did very well this year as compared to the previous years, and maybe a little bit higher because they're studying on their own. But before I continue to answer, I have to put a disclaimer. I'm sure many people would disagree with me, but I'm a person who is really pro-technology, and I think our future as medical school, medical doctors will be different. So I think in the long term, we will be replaced by technology, but we still have now the interim period. Hopefully I will remain within it. I still have 20 years of practice, but I think the future is really, we don't have really the human sitting. Maybe we're in the backgrounds doing algorithms, etc. But so that's why I'm putting two links. And this was my impression when in my talk, I said we need to do curriculum redesigning, because televisits were very successful and patients loved it also. And from a physician perspective, the only thing that you would not like about the telemedicine visit is the physical exam. In my opinion, the physical exam adds maybe only 10% to my impression after the history taking. It will fine tune my differential diagnosis. And even the physical exam is changing in the future. I've put two links. One from Medscape, where they did a virtual neurology exam. Like the physician was guiding the patient on how to do the physical exam, do like this, and he was doing a virtual neurological exam. Even I've put a link for Taito, which is it's an instrument where like the patient would be at home. It's a nice video. And I'm in my clinic, and then the mother would put the instrument in the ear of the kid, and I will see the tympanic membrane. She will put it at the heart, and I will listen to the lung exam. She'll put it on the lungs, and I will check the lung exam. So I think even the future of physical exam will be changing in the future, especially with the development of televisits. And this is why I think we were really emphasizing a lot about the face-to-face connection with the patients, when maybe the future it doesn't matter anymore.
Thank you. Very, very interesting. Please, John.
Well, and I would add to that, we need to bear in mind, especially our students, but even our graduate trainees, our young practitioners, they're different. I have dyed my hair silver, so to speak, and it's not as much of it anymore, but the young ones coming through have grown up with these technologies as being so normal. And, you know, the expression digital natives may be overused, but I think there's a huge difference in how someone who is 70 or 80 or 60 prefers to learn versus someone who's 20 or 25 or 30. And those learning preferences, they're not differences in how the brain is wired, but they are preferences and they matter. If we bring technologies forward that teach trainees the way they enjoy learning, they'll be more willing to spend time on task. And time on task is what the adult learner needs to do. They need to know why I need to learn this, and then give it to me in a way I like to do it. So I'll say I still like the live human contact. When I'm sitting with a student or I'm sitting with a patient, there's some extra chemistry there, but I can go a pretty far distance, and all of human contact. But it's really aided by who our trainee is, that young digital native.
Thank you very much, John. Very interesting. And then there was another interesting comment in the chat from Hector Guadalajara from Autónoma University de Madrid. And he was just commenting on a simulation and saying that, you know, also the organization of real life chances could also help to learn and can be sometimes even cheaper than simulation. Maybe this comment maybe is from for Hélène, if you want to comment further on that.
I'm not sure I understand what is meant by a better organization of real life chances to learn. Is it, you know, with video support, as Nadine was suggesting, is that maybe what we're talking about? Building libraries of real life chances, absolutely. But also, I mean, I see an opportunity, and we've started to apply that. This was also one of the effects of COVID, is the virtual simulations that we've started doing. So just last week, for example, I ran a simulation. It's a disaster board game for the ER group, but we broadcasted it. We live streamed it through Zoom to a much, much larger audience. So the people around the table allowed, at this time, given our COVID status, we were allowed 12 people in the room, but some 40 people were able to watch it. So if that's an example of a real life learning opportunity, then I think that this is an opportunity for digital technology to support expanding the audience. And that's just within our center, but there's no reason that that couldn't be expanded on a regular basis to send, you know, the centers. We're a tertiary quaternary care center, but to our centers that we support in our community and farther out. So, yeah.
Thank you very much. We only have a few more minutes. I have a very broad question, and I really ask you to answer in a few words. I know it's not easy, but I mean, one of the challenges that we are facing, you know, in this field, that of course all the opportunities provided by the digitalization are amazing. And of course, this tragedy of COVID-19 really accelerated the whole process. The thing is that, you know, to change the curriculum in medicine and in other health professions is not easy. There are, you know, many bylaws in different countries. You know, here on the screen, we represent 4 completely different countries, and we have different regulations. And very often what happens is that we add to the curriculum all these things. And it becomes too much for the students, because they have to learn very often in the traditional way, plus, as I said in my very brief introduction in the beginning, you know, digital aspects, ethics, communication, all things that we know they are very important. But I think we should not add just to the curriculum of the students all that. It should be integrated, and we should have the courage to remove a little bit something maybe from the previous. But you're more expert than me. Please, a very short comment.
I'll just say that I think I agree with you. I think we need to not teach more and harder, but we need to teach smarter and really choose what we're going to be teaching. Absolutely agree with you 100%. The other thing that I wanted to add is that I don't know if your situation is the same as ours, but we have a projected manpower, human power, woman power shortage in healthcare in the next foreseeable future. And what that means is that we're going to have increased cohorts of learners, and we need to be able to accommodate and receive those cohorts and to be able to teach them. So yet another reason to find better ways to teach them the stuff that they need to know.
Perfect. So just 1 minute each, please, very short. Thank you, Yumana and John. Yeah.
Yeah, so it's more of a thought for us to think about, because I always wonder why in our medical field we're always a laggard. Like all other sectors really move forward, like the aviation, the banking sector, and they kind of move quickly and smoothly. While in our medical field, we're always reluctant and still rely on very old, antique techniques, information that's easy accessible on your mobile phone. You don't need the memory anymore. So, but I don't have the answer why. I always reflect on that, but I have no idea why we're always that we stick to our old-fashioned methods and we don't move forward.
Perfect. Thank you. And John, finally, you are on mute.
What occurs to me at the end of hearing these presentations is the democratization of training opportunities, where the haves have long been major driving forces. And one of the benefits that we can realize here by making it possible for everyone everywhere to contribute, clearly in Pittsburgh, Pennsylvania, in the States, we are not experts on tropical diseases, but there's someone out there who is, and there's someone who's more expert at frostbite in the Arctic. And we each bring our special talents to bear. These digital platforms may be an opportunity for greater contribution from simply everyone to bring to bear what they have as their local expertise. So I feel there's a real opportunity here to shrink the world in these digital platforms.
Thank you. Thank you very much. And then one final word. I think we said that in the beginning. Nadine presented a very concrete situation there. We have to be very careful to the socioeconomic and to the digital divide in our countries and in the world. Some of these solutions, of course, are expensive, so we have to really make sure that they will be available to all hospitals, all different medical schools, etc. On the other hand, also digital solutions can help to save some money. So we have to try to find a good balance there. And of course, I can be also inclusive. They can offer to people who cannot travel easily, maybe in some countries also to benefit from this. So I think these things are not completely new because, of course, we have been debating about these issues for a long time. But this crisis of COVID-19, as I mentioned, accelerated some of these processes. So can be useful in a way after it will be completely over. Unfortunately, we have to close now. Many thanks again to the excellent speakers we had today. Many thanks to the participants. And many thanks again to AAHCI for hosting and promoting this event. Biba did an amazing job. Many thanks again to you. And see you next time. As I mentioned, we have 2 other appointments. I hope some of you will be present. We will talk about ethical issues on September 30th this year, and machine learning and artificial intelligence on October 28th. So I hope you will continue to follow us on the AAHCI screen. Thank you, and have a good evening or still good day for some people in the US and Canada.